So as much as it's 3 o'clock, let's call our Mason County Board of Health regular meeting to order, please. For our audience out there, why don't we go ahead and introduce ourselves? And Peggy, would you like to start?
I'm Peggy Van Busker from the North End, Hospital District 2.
I'm Gary Plews with the Fire Districts.
Dan Stein, Health Officer.
Dave Wyndham, Director.
Kevin Schutte, Mason County Commissioner, District 2.
Sharon Trask, Mason County Commissioner, District 3.
Lydia Buhite, Mason County Public Health.
Alex Pacey, Mason County Public Health.
Carrie Davidson, Shelton School Board.
Scott Hilburn, Mason General Hospital. Did you hear about our new building project?
Yeah.
Yeah, it's getting there,
Maybe
isn't it? It's
just,
getting excited.
Yeah. Got an invitation.
Yes, did you? Hey,
Yeah.
you're
Thank
welcome.
you.
You're welcome.
I got an invitation.
Introduce the other.
Oh, yes, please. Thank you, Peggy.
Oh, I'm Allison Smallwood, Mason County Public Health.
Dave Gardner, Mason County Public Health.
Amy Davis, Legal for Women Voters.
Tom Davis.
Great, welcome. Thank you. First order of business at this annual meeting, we normally go ahead and elect and appoint our new chair of this committee. And as much as I've done it for the last 2 years, I'd like to go ahead and suggest that Peggy accept that responsibility and lead us for another year. Would you do that, Peggy?
I wouldn't mind.
Thank you. I will make that motion. Is there a second?
Second it.
All in favor?
Aye.
Aye.
So now do
It's your meeting.
Okay.
just wanted to know
I guess
Check.
so do I have a motion for the agenda?
So moved.
I'll second it.
Any? Okay, all those in favor?
Aye.
And I would have a motion for the minutes from November 20, was it 27th? Oh, yeah, 26th.
26.
Oh, so moved.
Do I hear a second?
I'll second that.
All those, or is there any discussion? All those in favor?
Aye.
Okay, so let's move on to the health officers. Oh, I
How
guess I
about
better
the
do the,
resolution
sorry,
setting?
thank you. We have to.
You're new at it. You got an
Yes, well,
excuse.
not real new, but we have to approve the dates for next year's meetings. And I like the idea on here, if you look at the resolution, it's in November, it's the 17th, so we don't run into that Thanksgiving thing that we did this last year. And the January date is the 28th, not the 21st. But do I?
The November meeting will also be our annual meeting. This year we got off schedule,
Right.
so it's today, but our annual meeting would be November of next year, from this
Correct.
coming year.
So do I hear
I move.
I'll second it.
any discussion? So I don't think we have to really read the resolution. All those in favor?
Aye.
Okay, so health officers report.
Thanks for having me back again. For those who don't know me, I'm Dan Stein. I'm the health officer. So I just wanted to give a kind of brief summary of some things that we've been working on lately. Of course, being winter and kind of the infection time of year, we're seeing a lot of issues kind of surveilling the flu. Right now we had a bit of an early spike of influenza B this year, have been requiring masking for healthcare providers in Thurston, Mason, and Lewis counties. We're starting to kind of see that level even off and kind of start to reduce a little bit, so we're kind of just keeping an eye on that and also trying to figure out when influenza A is going to be peaking up. I'm guessing this might be kind of a bimodal year of kind of a B then A coming out. So I'll keep you guys updated with that. Of course, there's the big topic in the news right now, the new coronavirus coming out of China. We have a positive case in Washington. Nothing in the county. I haven't heard any rumblings of any possible cases or anything like that. The CDC has been very on top of it and has created some incident command centers and has been very closely monitoring the situation. And thus far, it's been very contained, and there haven't been any transmissions within the United States. So they've been doing a pretty darn good job so far. But of course, it's a brand new thing, so we're going to be keeping a close eye on it. We've been keeping an eye on. There have been some cases of mumps, hepatitis A, pertussis, and stuff like that we're kind of keeping an eye on as well. Looking out for close contact and whatnot with the hospital, in coordination with the hospital system and all that.
How many cases of mumps?
I'm sorry?
How many cases of mumps have you seen?
2.
2, okay.
Yeah. Recently. Abe, I guess, is going to be talking a little bit more in a little bit about some of the projects that we've been working on with the jails, and he's been doing a lot of great work of getting a peer involved in the system and getting medication-assisted therapy and Suboxone initiated while people are involved in the jails. So that's been a really strong success that he's going to be talking more about. Along with that, still working on my personal project of initiating hepatitis C screening and getting figure out treatment providers to help eradicate hepatitis C by 2030, which is the governor's goal. I recently put out a survey to the providers in Thurston and Mason counties to see if people are getting involved in treatment or wanting more information on that.
Did you get a positive response from the providers?
So far, I've gotten about 20 responses.
Up, down, or?
I haven't seen that. It just went out a couple weeks ago. Given a little bit of time.
Okay.
This is old news now, but I gave a talk and wrote an article in the Mason Journal about vaping, just talking about the vaping-associated lung injury and kind of continuing on with trying to fill the shoes of Diana Yu, who is doing a lot of the kind of community outreach and discussion about some community health projects that we're working on. The big one, though, is that I just wanted to throw out there is we're moving forward with our health coalition, and our next meeting is going to be tomorrow at the PUD building. I think it's at 3 o'clock. And we're trying to build this as, not trying to reinvent the wheel here, but trying to rely on grassroots organization to, and building a kind of an umbrella so that we make sure that the health department is working as a backbone organization, supporting a lot of these community initiatives to provide community health improvement projects. So we've gotten it sounds like we've gotten the Mason Matters board on.
Stood back up again.
Stood back up and getting the funding sources up and running, and we'll keep you guys updated. It's gonna be a fun new project. That's it.
Okay. Any questions for Doctor? Okay. So, I guess Dave, you're up.
Okay, so legislative season is in full swing, so that keeps us busy in Wasalfo, and then also in on the planning and building side of the world as well. There aren't any really big bills right now that Wasalfo is pushing really hard on. Last year we did get our foundational public health bill and the funding that went with that. So what we're working on this year is to get the funding that was actually promised delivered. So we were promised $22 million, we got $18.3, and we're working with the legislature to find a funding source that will make that full. Next week on the 5th, there is it's Public Health Day on the Hill. So if you're interested, come on up on the Hill. We're meeting downtown at 8 in the morning and give directions and contact if anyone wants to go. I spent this last weekend, Friday and Saturday, with some of Alex's team in Tacoma, getting our continuing ed credits for on-site septic systems. So it was a great conference. A lot of good speakers, but the biggest thing really was to sit down at lunchtime and at breaks with our local contractors and our local designers and to talk about things in Mason County and what we can do better, and then go look at the technologies that will allow us to do things better. And with that, we're also talking about making some rules change requests that would allow us to do some innovative things on the shorelines. So that was kind of exciting and fun. And I got to listen a lot. So yeah, it's all good.
That's good.
Just finished the last batch of death certificates for the year, and for suicides we stand at 12 in Mason County for the year, which puts us at a rate of about 18.4 per 100,000, which is higher than the state average. So well, we're averaging 1 a month, which is high. We should be about 8 to 9. So.
Are those a variety of ages?
Yeah, a variety of ages. So typically it's male in the 50s, mid-50s. Typically females, once they get past age 50, suicide rate drops to 0 or nearly 0. We are seeing some in the 20s. So that's, and I think that comes with some of our social media changes, and I think there's a lot of more pressure on teens as they go into adulthood, and I think there's just some problems dealing with the changes that come at that time. So
I know the schools are implementing some suicide prevention things. I was just curious if that where those age ranges.
well then yeah, so really it's any more 55 age men and teens followed by women. So
Dave, have you got any other county data that you can compare us with?
in about 3 weeks I'll have all the other counties.
Oh, okay.
So all that
To
should be
see
out.
if they've increased also.
Right.
With all the social media.
Well, and we're all talking about how the demographics of suicide is changing. That over 50 male demographic is still pretty much our number one, but we are starting to see a downward trend as those 20s pick up. So it's something I experienced when I was on active duty in the Army. We had a lot of suicides in that very young group, and it seemed like it was all relationship focused. Relationships went bad, they didn't have the tools to deal with those relationships, and they took their lives. Whereas people in their later in life, typically the underlying reasons are painful or terminal illness and or pending criminal action. So those are kind of the 3 underlying causes. So
What about the weather?
the weather has something to do with it. Fort Lewis has the highest suicide rate in the Army, and they believe a lot of that is due to the weather.
I know Grace Harbor has got that issue too.
Mm-hmm.
Yeah.
So that is part of it.
The SADS condition.
Mm-hmm.
Yep.
Seasonal affective disorder.
Yeah.
Okay, anything else?
I think that's it for me.
Alex, you're up.
Okay. So this time I provided you guys with kind of a year-end report for 2019. It's a little lengthy, so I won't read through it all, but overall just a very busy year. Several software changes that we went through with SmartGov and Online RME. Those are 2 programs that my staff deals with on a daily basis, so that increased the amount of workload that we have to deal with. Moving forward, 2020, I'll be looking at water quality program and trying to make some improvements with funding and overall capabilities within our department. Working with the commission on that, and also solid waste too. I don't know if it's necessarily new, but I'm finding there's a lot of solid waste cases out there as we go through our complaints, and residents that want to be in compliance with regulations, they just don't have the resources for it. So we're trying to put together some ideas and be creative with connecting people to these resources so that we can get these sites cleaned up. I think it's they become public nuisances if they're let go, and the owners, they don't have the capabilities. So I think we can do more on that. So we'll be putting some focus on that this year. Any questions on the report? Or?
Oh, it was well done.
It's lengthy, but a lot of info in there.
Yeah. When I took this job, I always wanted to. I came from staff, so I know how busy our department is. It's just go, go, go all the time, and I've always wanted to put these reports together. You know, it started out as I'm going to do this monthly. That didn't happen. It started out quarterly. Okay, that didn't happen. So now I'm doing these annually, and I'm able to complete that. So it makes for a lot of information in one report, but it's doable.
Yeah, it was good.
Are there any grant opportunities coming up for PIC programs that we're getting ready to apply for?
Yeah, so we're partners with our South Sound regional group, and we are currently contracted with them, and that ends in June 30th of 2020. And then our HIC-PIC program is picking up. I just got an update from Haley today. We should get a contract, she said this afternoon, so that should be coming up.
About another 100.
That's about another 100,000 for 2 years, so that's not quite a full.
That was really underfunded in our last round, and it seems like miraculously the federal government has found more money for it. So.
Yeah, it sounded like they were going to get a little bit more money. Overall, these grants are getting very competitive across the state. There's lots of agencies and departments that are going after the same amount of money. So, and it varies. It depends on the need. You know, they go to where it's needed in the Puget Sound, and you know, these projects are based on risk and where the need is really. So it varies on how much we can receive.
Okay. You're up, Lydia.
So I sent out my report, a 6-page report with the data about all our programs. That gives you more of a part of knowing what we do. Keeps you abreast of what we do. Just like Alex, we're busy, really busy.
Yeah.
Feel like we're running all the time. Any questions from the report you guys got? Okay. And then Ben Johnson wanted me to, our substance use disorder prevention group, wanted me to let you all know that North Mason is having a prevention summit that is a series of 3 things that are being sent out. So I'll pass these around. Sorry, gave me one, and I had one, so I'll pass these around. But February 19th, they're doing an e-cigarette 101. Bringing in speakers to do these things, and then March 18th they're doing a social norms event, and then on Wednesday, April 22nd, they're doing a current science on cannabis and alcohol implications for prevention.
Who's sponsoring this?
This is done by the DBHR, the money we get for prevention that we give to the North County, and then Shelton has some as well. And so their coalitions, their prevention coalitions, determine what they want to do. Right.
All the sponsors are on the bottom of the flyers.
Yeah, so I'll send those around and take a peek.
That's excellent.
And that's all I have on that, and then I will jump into the opioid report. Is that okay? So, Abe, I'm going to have you enlarge that quite large. Because I can't read that, and I think I'm going to go to this side. So I can read.
I'm never in a position to actually watch this. It's the first. It's usually one.
Good right there. Okay, we're good. Okay. So we wanted to give an update to the board on what's been happening with our opioid response that was started back in 2017. We're really entering, not ending, but some of our grants are ending, have ended and are ending, and we've also applied for more. Currently on the edge of our seat waiting to hear about another federal grant from a foundation that we applied, and we're supposed to hear this week, and we haven't heard anything yet. But it's something that we did in collaboration with Mason General Hospital on this other grant. So we'll see what happens. So the different programming that we currently have is prescription drug overdose, which is the one that started us out in 16 from the Department of Health. And it ended in August, and they replaced it with one called Overdose to Action. It's another grant funded by them, doing pretty much the same stuff, but just a little bit more shift in some things. And you'll see that in a minute. And then we have our comprehensive opioid abuse project. That's our federal grant, and we just found out, Abe and I, that we have to fly in March to DC again. Just found out. So That'll be kind of interesting because they'll have all the cohorts there now from 3 years, and we'll be meeting with a lot of different people doing a lot of different things. So it'll be interesting to see and come back with some reports on that. And then our substance use mobile outreach, which includes our Syringe Exchange, it still has a few more years to go. And we'll be talking about all 3 of these real quick. And I'm going to speak quickly. You have the slides, but I don't want to take, I guess we're doing okay on time, aren't we? So I guess I don't have to speak quite that fast. Okay, go ahead. So I'm going to start out. Normally I would have Christina do this portion because these are the projects that she's been working on, but she is on the Substance Mobile Outreach RV right now doing that work on Tuesdays and Thursdays. So we have the 4th highest death rate in the state of Washington from overdose from 12 to 16. We received the grant from Washington State Department of Health. That was the PDO grant, which stands for Prescription Drug Overdose. Sorry, just blanked. We said it for months and years. Funding started as a baseline project that in turn created opportunities in many areas surrounding substance abuse. That really was our foundational grant, and it was kind of surprising because they just said, well, it's only for 4 months or 5 months, and I'm like, what? So we started it, and we applied for the COPE grant because we thought it was going away, and then it didn't go away. So that was good. Countywide approach has advanced remarkably in the 3 years since the grant began, and it has a direct impact on Mason County's community health.
Lydia, going back to number 1, we're the 4th highest in the state. Is that per 100,000?
Yeah.
How's that
Yes.
measured?
Per 100,000.
Yeah, per 100,000.
Wow.
Yeah. So the objectives of the PDO grant was they were deliverables by the Department of Health. They basically told us what they wanted us to accomplish, and we were following with overdose patients in Mason County to connect them with evidence-based substance use disorder treatment, and we were also to collect opioid overdose data. So we had to set up those systems, provide technical assistance, training, consultation, and resources regarding opioid prescribing guidelines and opioid use disorder, provide public health outreach, education, training, community around opioids and opioid use disorder, and increase prevention activities such as naloxone education to include law enforcement, discuss overdose response and prevention efforts by the Sheriff's Office, Tribal Police. So those were all the things we started doing. All of those have been accomplished. We're continuing to do things, but we've accomplished all of them. So the results. In the Objective 1, we follow up with overdose patients in Mason County. So these are some of our statistics. We had non-fatal. Now these are reported, so there can always be overdoses that aren't reported. So reported overdose non-fatal we had in 17, March to December 17. January, December 2018 we had 26. And January to December in 19, we had 52. That can be, not because we've had more overdoses, but because we are now collecting the data and there's a lot of education and we have partners working with us, so we're actually getting more data. And that would include and you can jump in anytime and add things, Abe. That would include our EMS partners getting on board.
Yeah, so when we first started, most of that data was coming directly from the hospital. So individuals that called 911, ambulance got to the scene, and then they were transported to the hospital. As we moved forward, we were able to get more and more EMS partners or fire department to give us reports, because a lot of people that have an overdose, firefighters respond or EMS responds. They're like, I'm good now that I'm awake and with it. I don't want to go to the hospital. I don't want to get help. And so they may not have been reported on if they didn't go to the hospital. So we're trying to get as comprehensive of a data as possible.
So then with fatalities, in 17 we had 5, in 18 we had 2, and we thought we had none for a while, and I'll explain that as we go to the next one. In 19 we've had 12, which we call preliminary data because we don't get the coroner's data for sometimes 8 to 12 months. So that was why we went from 0 to 2 in 18, because we had no record of any, but then all of a sudden the reports came back in that there was toxology reports that they had fatal overdose, and that's what it was due to. So we're a little more cautious when we say numbers so we always say preliminary now, because we have to see what goes on, and the state does the same thing. And then we had the number of survivors contacted, which may also include family contact, averaged 5 to 8 for the 3 years. That we found to be very hard. That was what originally DOH thought we were going to go do. We were going to go contact all these people. Well, they don't want to be found a lot of times or contacted, so it became a little bit more difficult than we thought. As everyone that worked across the U.S. has found the same thing going on.
I will say, though, both mine and Christina's experience, for those people that we have been able to contact, it's been a pretty amazing experience. There have been some individuals that we have seen. One of my first contacts I had back in 17, she's a couple years in recovery, working for an agency that helps individuals get into recovery as well. So, and Christina has similar experiences and stories as well. So, some people and family that we have talked to, it's been a pretty overwhelming experience at times.
Let's focus back on that 12 and the extreme jump there with the Narcan and the outreach. How is this happening?
Well,
Penny toxicology.
Well, no, go ahead, Dave.
Well, so we don't know yet, and that number may get larger depending on if we get more cases as well. We do know that there has been an uptick in fentanyl cases. We don't know if that's the case in our community yet. We're waiting on the state's help to look into that number and to see if that number is going to continue to trend up or what that does. Back, I believe, in 11, that was as high as our number had gone, was 12, so we're right back up to our peak. And then it kind of steadied and then went down again. So it's kind of too early to tell, but there have been reports anecdotally from our mobile outreach program that there's been pockets of really strong dope at certain times of the year. And so we're trying to keep our finger on the pulse there, but there's so many different factors that could take part in it.
And I'm curious again too about the age range. Is it all over the board? Is this 20 and above? Are we seeing teenagers?
It's no teenagers.
Okay.
It's actually fairly all over the board for the most part. Anywhere from 20s, mid-30s, 50s, 60s, even. And that's actually fairly consistent on our overall substance use numbers as well, people seeking treatment and recovery. But if we were to say if there was a majority, it's mid-30s.
Is there a huge uptick in Kitsap, Thurston, Grays, Harlem, Jefferson?
Everybody, it's across the board.
Like this?
I don't know, because we don't get their individual data like this. We're small enough that we're collecting this separately, but.
Yeah, some of those numbers haven't quite come out yet for this past year, but since we've been collecting it ourselves, we're able to present what we have to date.
Yeah, so normally the state won't release the 19 data for a while yet, so that's the way we normally would get it from other counties, but they don't release it till, well, it's normally March, but I think last year was June.
Yeah.
So.
And I think, as we've talked internally at Public Health, as we look at that jump and as we see the number of deaths increase, it just reiterates the importance of the work that we're doing and the importance of the leadership and support we've had from our community, and the fact that why we take it so seriously and looking for funds and looking for programs and continuing to do the work we're doing. So we greatly appreciate the support that our community
Because rightly, it could have been 52. Instead of 12.
Well, the reason why I'm looking at it so deep and I'm questioning it is there a possibility that we are screwing up here by presenting a situation where they're becoming more the belief that they're going to be able to come out of this and they can push harder? That's just such a huge number. I just have a hard time seeing it not coming from something.
So there's other drugs too involved here.
Yeah,
Now,
I think it's
to be honest, though, this is opioid. It has to be opioid in this, because Dave was telling me the trifecta effect of different drugs. We do have a lot of different drugs. We're hearing now that meth is back on the rise again. And the combo seems to be, we're having a lot more combination drugs. When I look at the reports I get from the hospital and see, I do want to say, not for fatalities, but our biggest problem actually lies in alcohol still, which is kind of shocking. It really is alcohol still that's the #1 drug of choice. so to speak, so where people are ending up in the hospital.
And some of these are polysubstance,
Mhm.
but if there's opioids involved, they're counted as an opioid-related death. And the data coming directly from mostly syringe exchanges and programs that are providing naloxone and Narcan is there's no data yet to show that is the reason why there's an increase. So when they're gathering data, asking, because each year they do, well, I think it's every 2 years, UW does a survey, an extensive survey for syringe exchange, and those are some of the questions they ask. Does this increase your use, or do you use more if you have Narcan on hand? And none of the answers or responses are indicating that that's the case. So,
Thinking about, Randy's concern, do we have any data on number of arrests by local law enforcement agencies? Have they seen a large climb like this too? In other words, is the population just using more and more and more, so consequently we're going to go ahead and see more on our end?
Well, I know
Or
in
is it
2018, that one of our locals had the Superman syndrome. They did it, they came back, they didn't stop. And I just was wondering, but that was one of the two. So.
Well, let's move on and show some of the other data that we have so you can see it in perspective. So yes, there is an increase. We'd always, especially after our 18 year, we were all excited. But, people come and go. Basically, we got to look at treatment because that is what's going to help everybody along the realm. I believe this could be higher if we didn't have Narcan. Because the number of people that are not coming in to the hospital or reporting and are being saved by Narcan is huge. So at least the Narcan's out there, we're not seeing that number be in the hundreds. And we're getting good connection with the people now, with the opioid users, which is we didn't have before. We didn't have conversations with them, and we're having them now, getting people into treatment. So, oops, did it jump on?
No.
Oh, okay, good, thanks. So again, hospitalizations due to overdose. It's hard to see. The bottom line is red, any opioid. The top is any drug. I think it's black, but it might be green. And then death rate due to opioid overdoses. And this is the years that we've collected data from the state. So there was a jump in 16 and 17. We, of course, don't have the data yet for 18. It takes 2 years for the state to get the data out to us. So we're collecting some data a little premature, but it hasn't been confirmed by the state, but it's our own data because we're doing a big data collection with our COPE project. So we're watching things more closely. And Dr. Yu did make overdose reportable. And so not all counties have done that, even still yet. And so we've been collecting some data from that. So we have a few years of data. The state now is collecting more than they were before. So objective 2, we provided technical assistance, training, consultation, resources regarding the prescribing guidelines. And these are some of the things that happened. And many of you have attended many of these things that we have been doing in the community around this. I think it's really pulled our community together for not just substance use disorder, but for other projects that we're working on together. Here's prescription rates have decreased from 105.3 to 72.8 between 2015 and 2019. So that's good, because this is how this all started, was about prescription drugs, if you remember. It wasn't the illicit drugs, it was all about the prescription drugs. And of course, providers also changed their practices. I don't know if you've had a surgery recently, but it's very hard now to get pain med. So we swung to the pendulum in the other direction, which I don't know if that's a good thing. For those in pain, it's not, but at least they've got a handle on that. And then here's objective 3, the community public outreach, which that's the table that they set up, that particular one, but they go to the transit center every Wednesday, and we have partners with us, not just public health, that offer services and appointments and giving people Narcan as well. And then speaking into the community, Christina and they've done tons of trainings in our jails with community partners, agencies. 698 people, including 195 inmates at the jail, were trained in overdose recognition and response between 17 and 19. this year's 1,306 naloxone kits were distributed. Out of 92 people who reconnected with Mason County Public Health to get a refill, 40 individuals had used their kits to successfully save someone's lives. So we do follow up with DOH. We follow up on when the kits are distributed. They have to agree to fill out a form and return it to us. So, and then it said 56 individuals gave kits away to someone else in need. Increasing prevention activities such as naloxone education with law enforcement, overdose response training. Naloxone is supplied to Mason County Sheriff's Department, Shelton Police, Tribal Police, DOC, Department of Corrections, field officers, and Shelton Police really started the naloxone training. I want to give them that credit. The city police were the ones that started this whole ball rolling, and Chief Moody had all his officers carrying naloxone and trained.
Real quick, going back to that, when there's 1,306 naloxone kits that were distributed within the community, are those reported back from the pharmacies that are handing those out? Or
No, they don't hand them out. We handed them out.
Those are the ones you
Those are the ones we
handed. That
handed
doesn't
out.
include what
Anything
pharmacies
else
are-
that went out in the
That doesn't
community,
include
right.
pharmacy
Does that
prescriptions,
include
which
fire
we've
departments
done
as
a
well?
lot ourselves.
My husband has too.
Yeah.
It
Yeah,
can
so
include
I
the fire
was
departments
curious about
that we supply. This is only the supply that public health did in the community.
Okay.
There's been other supplies as well.
With all the new opioid regulations, if someone goes to a pain doctor and gets an opioid, it's pretty much required that
Yes,
they
now.
have the Narcan.
Yes, now it is.
Yeah.
Yeah. Wasn't, but now it is, so it's good. And actually, the supply of it's dwindling. We're not getting the free supply we used to get. So that's a new thing that the state's kind of looking into in the federal to figure out what to do about that. It's not we don't have enough, it's they're not giving it free anymore. And it's a little costly.
Yeah, it is.
Increasing prevention activities such as the education to the law enforcement. Did we say that
Yeah.
already? Okay. What have we learned through our outreach interactions? So overdoses witnessed during the grant period. So 0 overdoses, 243 people reported that. 1 overdose, 72, 2 overdoses, 37, and 3+, 62. Self-reported overdoses, 0 was the highest, 54, 1, 11, 2, 7, and 3, 7. Was naloxone used to reverse an overdose? 40% said yes, 87% said no, meaning they didn't use it for that. Where are the opioid overdoses occurring? So we had private home is the highest number, and that's consistent with what the EMS finds. 31% of the individuals reconnected with after the initial overdose response training used naloxone and training to save a life. So 31% is pretty good because they have to reach out back to us and let us know that they used it. Then was 911 called. 21 that answered said no, and 17 said yes. Kind of split there. Why was they not called? Don't know. Patient awoke and could handle it. They wanted to avoid the ER. They were afraid of the police, and no phone service. Short-term outcomes, you can see there, we wanted to increase. So this is the new overdose project that they're now funding us to do. It's called Overdose to Action, or OD2A, and we're increasing awareness again, improving coordination of public health safety efforts, using shared data to inform collaborative public health and safety prevention, which that's new because the state wasn't collecting anything when we started the last one, and they now are collecting a lot of data, so they're having us do. We're already collecting it, so we were gifted that. We already have it done. Increased awareness of the risks of prescription illicit opioids, intermediate outcomes, improved utilization of evidence-based approaches to prevention, intervention, increased fidelity to opioid prescription and medication protocol. So those are, again, what they gave us at the state that they want us to work on. You have this in your packet in the back. It's really small in your little packet, but it is big in the back of the packet. So this is what we worked on in the COPE project, and sorry, I'm going to turn it over to Abe, but this is what we created and the network that we're working on for the Comprehensive Opioid Abuse Project that's federally funded, and we have 9 months left on it, but we're asking for an extension of 3 months, which we should get because they didn't give us the money for the first 3 months. So we're going to be extending it out a little to the end of the year.
Yeah.
Go ahead, Abe.
Yeah, so as Lydia had said in the beginning of the presentation here, when we first received the funding from the state about the PDO project, it was only what we thought to be just a few-month project. So we applied for the COPE funding, basically thinking that we would just continue the project that we had started. We found out shortly thereafter that the state was going to continue that funding, and then we found out we got the COPE project. So we, after having conversations with the Bureau of Justice, decided to shift the COPE project just a little bit, as we knew we were going to take care of the overdose prevention and education and outreach. So what we decided to do is kind of take a look at the treatment and recovery system as a whole, things that kind of public health isn't a provider of any specific service, and we could kind of oversee or see the whole system. And as you can see, it's pretty intricate. There's a lot of moving pieces and a lot of things to kind of look at, and we didn't feel like there was one entity that was kind of trying to bring it all together and have everyone kind of working for the same goal. So this was a way for us to kind of get a visual and see all those moving pieces. And we wanted you all to see that. For the COPE project, it has been an emphasis on partnership and collaboration. So we have 26 formal partners that have signed MOUs and letters of participation in this work. We have our county leadership, city leadership, school districts, tribal nations, substance use treatment providers, fire departments, you name it, and everyone has been willing and has been participating in this project. In addition to the coordination and collaboration, there's a data collection piece, and you'll see some of the numbers here in, I believe, the next slide, but we have 6 different agencies that are voluntarily collecting data for us. 5 of those provide substance use disorder treatment. Another one is a faith-based discipleship that works specifically in kind of behavioral health area. This has been fantastic because it's giving us real-time data, allowing us to make real-time decisions and really driving conversations about what is happening, how many people are accessing treatment, how many people are being referred, what types of referrals, what types of treatment are people seeking. And hopefully after a couple years of data collection, we'll have a bit more of a concrete picture about where can we maybe focus more efforts. What do we need to add more medication-assisted therapy? Do we need to add maybe cognitive behavioral therapy with medication-assisted therapy? Whatever those scenario is, that's what we're hoping to get some data on in our community. We are moving into our 2nd year of that data collection, and all of the agencies are still voluntarily, sometimes not happily, but voluntarily still collecting data with us, and we greatly appreciate that. It's pretty awesome. Some of those conversations, so for a while now, we've been doing our bi-monthly larger stakeholder group meeting that I think everyone here has been to. We've also been having monthly treatment provider meetings. So all of those agencies have been coming to the health department monthly. We've taken a break here or there when things have kind of gotten overwhelming for the agencies, but we've all been meeting, going over the data, what they're seeing is working. They've had input on what questions, what data is useful for them. So it's been a really kind of a cool experience, and not just the actual data collection, but the conversations that those agencies that they're having at the table. You know, hey, I need help getting people in inpatient. Oh, I'm great at getting into inpatient. I have a lot of connections. So then they're having those conversations about how to better provide services for the individuals they're serving. And I think that's been extremely fruitful for this part of the project. Here are some of the numbers that we've seen. So there have been 1,453.
Sorry for my December.
So this is up to October, December. but 1,453 unique individuals that have entered in the treatment and recovery system.
So one of my questions when we started this work was, well, how many people are in substance use disorder in our community? And no one had the answer. So we now know at least those that we've been able to track, and we track them through numerous different organizations. So it's not just coming to us or us finding out about them. So I'm sure there's more than that, because we're not tracking everybody. We don't track those that are, these are mostly Medicaid individuals, so we're not tracking people who are under insurance that might be having services, so.
Yeah, I believe there's 2 agencies that are providing SUD services that are not involved in our data collection locally. A third just voluntarily added themselves to the list last month. So the top 2 numbers you see there, the recovery support, that has been a point of emphasis for us after the first year of data collection, knowing that how important everything else is besides just treatment for SED, but transportation, housing, childcare, you name it, anything else that has to do with providing support for somebody along their path for recovery. And so that's kind of been the main topic that we've been discussing in our treatment provider meetings and at our stakeholder group meetings, is what does that look like for each agency, and how can we possibly raise that number? And then you see the other percentage there. And
Do you want to go?
yeah, sure.
Mm-hmm.
So,
You're on it.
so this is our substance use mobile outreach program. This includes our Syringe Exchange. That is a picture inside of our Connex box that Alex helped us get. Those are all full of syringes, right there, of used syringes. We're getting close to about half of that Connex box, and we just completed our just over 1 year now. It was November was our first month. We still have our 4 locations. Tuesdays, we are in Belfair from 11 to 1, out in Skokomish from 2 to 4, then Thursdays we're out in Camilchi from 11 to 1, and in Shelton from 2 to 4. It is still a 1-for-1 exchange, so somebody needs to bring a syringe to get a syringe. And we continue to partner with local treatment providers. We have, more often than not, a peer from our community that sits on the bus with Christina and is able to provide support and is able to connect people to services if they're ready for them. And there's been several instances where we've done that. And I can tell you, personally, being on that RV, and sometimes it's the one place people feel safe about talking about where they're at. There's been, just like the overdose calls, we have some pretty powerful conversations, and it really drives home the reason why we're doing this work. So we have exchanged almost 150,000 syringes to date. We have 390 encounters, and 207 of those are the unduplicated numbers. So if you subtract those numbers, that's the amount of people that have repeated or gone back and used it multiple times. Oftentimes a person will exchange for more than one individual, so there have been 683 people served by the program. We offered naloxone to everyone that is on the bus, and we've given out 50% to those individuals. 64 reported successful overdose reversals. It's a pretty big number. And we've done 37 referrals of warm handoffs, meaning we've made the call, we've set up transportation or whatever that is to get them connected to the next point in their journey to recovery. And here's just some demographic information. Some of it we've actually been fairly surprised with. For instance, the housing percentage, 82% of the individuals using these services are housed. Only 18 indicate that they do not have a place to live. The age range, as you can see, the 46 to 55, 24% of the individuals. Of course, the 26 to 35 is the largest percentage, and the gender percentage as well. As you can see, the race and ethnicity, that number has gone up quite a bit once we moved our Skokomish site. We were right next to the health clinic, and we moved down off of 101, and our numbers there have gone up. We're still working on participation out at the Kimochi site with the Squaxin tribe. It is used, but not as much, so we're working with the tribe as to how we get the word out, how do we build trust, what's the best location. We've moved it once so far, but we're constantly looking at how can we improve these numbers and access for individuals. And these are some more statistics. The heroin's the #1 drug of choice, followed of course by meth. There are people that come in exchange that do not inject, that exchange for other people, that exchange for friends, that have other drugs of choice. They may just, not just, but they may smoke marijuana, drink alcohol, and their friends use, so they just want to make sure that their friends are safe. And then 38% of the individuals have overdosed, 59 have not. This is, these statistics are comparing what our numbers were before we started the mobile outreach as to now when we have had it. You'll see a dramatic increase in some of the, well, not always dramatic, but an increase in some of the numbers. What this is indicating for us is we are able to reach more consistently and in higher numbers of at-risk population. Again, here this is a comparison. The most significant number you'll see is the 3+ overdoses. So previously we had contacted about 19 people and now 55 individuals. All right. I believe this is our last slide. So as Lydia mentioned before, we are working on some other projects, and a lot of the work that we have done have led to other community projects. The quick response team, that is a project Fire Chief Bo Bakken had applied through from North Basin Regional Fire Authority in partnership with Twin Isles Community Health. That is up and running. They did their rollout last month, and so they're up and going. And that was the second year of the COPE project, so they'll probably be heading over to DC with us in March.
Yeah.
But I'm really excited about what that program is and does. For those that don't know, it's a program that they've got a bus, they're mobile, it's a team. There's 3 members on that team. 2 are substance use disorder professionals. 1 also is a mental health professional, and there's a peer/community health worker, insurance navigator on the team as well. They are working on overdose follow-up. So instead of us at Public Health Department making a call, they're able to go to their place of residence or where they're known to reside and offer them services directly. As Bo's always wanted to be inventive and get the most bang for the buck, he's also it's been a big conversation and work to provide more than just that. So right now, the community is going to shape what that program is. They're willing to do mobile assessments. They're willing to do transportation if there isn't any available, as well as some care coordination. So trying to fill as many gaps as possible. So that's a fantastic program. We're also working on a jail map program. We just started a month and a half ago. And so I'm going into the jail right now, on average about every other day, Monday through Friday for a few hours a day, and meeting with individuals, talking about what's going to work for them for their path for recovery and what that looks like, and if medication-assisted therapy, meaning Suboxone, Subutex, patrol. If that is something that they think is going to benefit them, then we talk about what that looks like. We are able to start them on the medication before they leave. Right now, it's moved to about 10 days prior to their release. They will be started on the medication. And part of what I'm doing as well is making sure that they're set up before they leave jail. So making sure they have an appointment and a provider once they're out, whether they need transportation, whether they need housing, all those other recovery supports that are essential for success. So I think we've started about 4 individuals so far. It's really new. The medical staff, it's really new for them. The jail staff, it's really new for them as well. So as you can imagine, there's a lot of growing and learning to do for everyone. So the leadership over there has been fantastic, really supportive. We've come a long way, but we've got a long way to go. So I'm really encouraged with that. And when we find out this week that we did get that grant, thinking positively, it would really bolster this program and grow this program. So more to come on what that looks like.
We were one of 488 applicants across the U.S., and we were one of the 88 that were chosen to put the application in. And they're going to probably fund half of that, about 47. So,
and
fingers crossed. And that's something. So the purpose of it was we wrote it for the jail mat treatment as well as working with the hospital emergency room. And so that's kind of the connection we've created, and that's our goal is to. So we thought we'd have somebody else be able to go in there and start it, and it was not happening. So we decided we'd go in and start and just see what we could start with. And I'm so glad we did, because we've learned all the ins and outs that we were going to have to work in this program. That would have been hard to just turn over to somebody we hired brand new off the street. So it's going to make it a lot easier to get the grant. And if we don't, we do have a backup plan.
And can't emphasize the importance of a MAP program in the jail. A person is once they've had a long distance between use, so when either they go to inpatient or they go to jail and they get out, I forget what the statistic is, but they're way more likely to overdose and potentially die. I believe the number is if somebody's on medication-assisted therapy, it's something like it reduces the chance of overdose by like 86%. So I think it's obviously our long-term goal is health and recovery and long-term. But if we can at least prevent the overdose and the overdose deaths, then I think that's a win.
And how many of the inmates are dependent on drugs?
Dependent? Mm-hmm. We'll know more because we're asking more questions now. It's been a hard number to put to kind of quantify because more often than not, a person is not going to disclose that information for fear of more charges, for fear of interaction with jail staff, or whatever the case may be, stigma, shame, that kind of thing. But I believe the chief has said, at times up to 80% of the population is dealing with substance use or mental health issues. And so it's pretty significant.
Okay.
There are a lot of individuals that are.
So if we can offer MAT, we can help them get into treatment, get them started in jail, then they're not leaving the jail and heading back to their deal or whatever. And maybe they already feel like, oh, this is working for me. And more likely to stay in treatment is the goal. And then we hope to see by keeping data, will we reduce the recidivism of people coming back into jail? Because a lot of times they've got drug charges, that's why they're in there, or they have theft charges because they're trying to support their drug use. So we're that's the trend, that's what we're hoping to try to impact.
And the most recent and current project that we are pursuing is the Law Enforcement Assisted Diversion Program. The commission was gracious enough to provide some funds for a grant writer for us, so we aren't doing actual grant writing, although at times it's felt like we have been. It's due, and to give you a little bit of history, so it's some monies that were allocated for a LEAD specific program. LEAD started in Seattle in 2011. It was House Bill 1767. It brought down some money to the Healthcare Authority, about $4.9 million, and another $1 million to the Washington Association of Sheriff and Police Chiefs. It was due on the 23rd, but they released it right before Christmas, so they realized that let's give them another week. So it's due this Thursday. And this is a project that our Public Defender's Office, our Prosecutor's Office, our Sheriff's Department, our Police Department, county leadership, city leadership, and a lot of community-based organizations are really supporting. And so we're looking forward to seeing what we can do with this. It's a super quick turnaround. We'll find out in February if we get the grant, and they want us up and running in March. To give you an idea of kind of what the program would look like, there's a policy group, and there's an operation work group, and then there's the behavioral health agency that does the kind of intensive case management, and of course there's a referral process from law enforcement, and public can refer as well to this program. It's a pre-booking program, so there'll be kind of a group of crimes that the prosecutor, public defense, and the policy team kind of comes up with that will determine who's eligible for the program, and it'll be substance use related and mental health related. And so, say I'm out in the community, I commit a crime, it's related to substance use. The officers will be trained in how to work through a conversation with the individual, but basically they're saying, hey, there's this program. You have a choice of doing this program, or I can arrest you, take you to jail. If they say they want to do the program, then the process starts. So essentially it's trying to divert people from incarceration and really work on treatment, recovery, health, and wellness. So I'm really excited about it, and we'll find out next month. So hopefully by the time the next meeting happens, we'll have some information on it.
Questions?
So great, I think really informative presentation. I'm looking forward to maybe spending a little bit more time with the data and seeing what I can glean from that. But one of the things that I've throw back to you and look forward to a response on is we saw the increase in fatalities and opioid related fatalities. Is that the best or only metric we should be looking at to determine success? I mean, given what addiction and active use is like and how many times you have to go through, some people have to go through the process of recovery, and it's not a linear process. What should we be looking for to determine whether or not we're being successful?
I think that's a great question.
Yeah, so the COPE grant is kind of our opportunity because that's where we're doing all kinds of data collection. Finding out about recovery, are they staying in recovery, are they being supported in recovery, and that's where we have a researcher that is being paid for from that grant who's actually doing a research project, and he's very excited about it because he's talked across the whole U.S. and says everyone he talks to is very excited because nobody's done this kind of research before, and it's the networking of how do you support people in substance use disorder. How do you make them successful? What can we do to be more successful? So that's the data that we're really actually looking towards. So fatalities and overdoses is how this all started, and we do have to keep and track that data, but we're looking more on, are we getting people into treatment? Are they becoming successful? Are our treatment providers giving them the support they need? If they're falling out of treatment, why? What are we missing here? Why? How can we help support them? So those are the things that I think are going to show our success at the end of the project, is our goal, is what we're looking for.
And kind of as a follow-up to that, what counts as a fatality in our county? Is it a resident of Mason County having a fatal overdose in Mason County, or if you're a resident of Mason County and you go over to Thurston County and you're using there and you have your fatal overdose there, does that count against Thurston? Or if because you're a Mason resident, it counts here, and vice versa?
One that we've talked at length with University of Washington and Department of Health. Because right now, they are counting where the overdose occurs.
Yeah, the state does.
The state does.
Yeah, our numbers, we're counting whether you're a resident or not, an overdose that happens within Mason County.
Right. So it is, with all this going on across the whole state, they are rethinking how they're collecting data and what they're reporting. And that's one that we have asked them many times in the very beginning. We've actually, because we've had these projects and been working, we in Snohomish and some of the few, Clallam are the 3 counties that started the work. So we've had a lot of questions that I believe has informed Department of Health and how they've shifted some of the things they're doing and reporting and looking for. Because that's huge. You know, if somebody drives through and overdoses, okay, we're gonna take care of them and everything, but they weren't in our community. They weren't part of our community.
In particular, I mean, when you're looking at other counties that don't maybe have as robust a program as we do, you know, how does that factor in? I guess it's just, you know, kind of a.
If you're interested in that, Kevin, the last I looked, the state is reporting both those numbers now. So they're reporting it as residents that overdose versus where the overdose occurs. So they are reporting it 2 different ways, so if you're curious.
Yeah, because they weren't for a while, right?
They weren't until we brought it to their attention, and I'm sure other counties did
Right.
as well. Yeah. And now they are, so.
And I know too that if it was polysubstance, they'd count the same individual multiple times.
Right.
Under one substance, another substance, and another substance.
Interesting.
So we've addressed that too with them, that they need to think differently about how, because it skews data, especially for counties like ours, which is a smaller county. A few numbers can be quite a skewing of our data. So, yeah, they've been very cooperative.
Lydia, if you had a bucket of money and a big staff,
Ooh, I'd love to have that.
yes, how can we address this problem to a higher level? What can we do?
I love the question.
I figured you would.
I would like to
You wrote it down right here. Say, Scott, would you mind?
I did that.
You got my email.
I would love to see in each community a fully comprehensive center that handles everything. And I'm going to turn to Abe because I can't remember the name of the tribe, which is doing it up north. The Swinomish tribe, where they have put a community center and they have the mental health there, they have the substance use disorder, they have food bank, they have childcare, they have transportation.
To and from.
Services facility that would have, you know, all those things in one. It would be big enough to serve our 5-county region. So that's one of the things that we've proposed, and OFAM has given some feedback, and now we're kind of going through the process of looking at their feedback, and we'll go back to a more firm proposal.
Think it's doable?
The money's there.
Is it?
It just depends on how they want to divvy up the money. If they want to go through, say, 4 or 5 regional centers, or if they want to distribute it across the state, because it really affects, you know, your ability to do bigger things.
Right.
Do you have any comments to his question? You can perceive all different perspectives.
Well, for our department.
And our community.
I think that it's been super beneficial for us that we found out when we were able to transition our COPE focus. And my position was kind of morphed into really looking and coordinating the whole system. Whereas it wasn't as project focused necessarily. And so I think a position like that, either permanently in each county or each community, I think would go a long way, you know, because it allows for the opportunity to reach out to other agencies, pull other agencies in, encourage the work beyond silos, because oftentimes a lot of the agencies we've been speaking to love what we're doing and they love participating, but they're so overworked and overburdened in the work they're doing, they don't have the opportunity to reach out. So having somebody reach out to them has been, I think, really important.
The coordination is huge, and that's why this project and the research going on the research are so excited about because it's not happening. Looking at how do you best coordinate a community. And we're small enough that we can do it, which then they could replicate it in other communities. So there's a lot of good work going on. And we look to the East Coast because they're kind of ahead of us in this. It started a lot earlier down there, and they've got numbers that are off the charts. And they're doing some very innovative things in dealing with these problems. And housing is one piece of it. Having housing is huge. You are not going to get mental health or substance use disorder under control if people don't have safe places to live, because they need that to start with, and the support. So that's a huge one, and everybody's agreed that that's one of the things that money needs to go to as well, is to get the housing stabilized, the low-income housing. So I have just one more thing that I'm supposed to bring up, and that's the update on the managed care organizations, which have, as of 2020, January this month, have taken over the behavioral health services for the Medicaid services, and funding that. So basically, if, like Consejo is one of our mental health providers in the community, they have to get authorization to get paid Medicaid dollars for the people they see. Where it used to go to the behavioral health organization, the Mason Thurston Behavioral Health Organization, so that's been a huge change. In our housing and behavioral health meeting last week, we discussed it, and we have Mark Freeman from the Administrative Service Office. They're changing all these names. The BHO doesn't exist anymore as of January 1, and so the Administrative Service Office is kind of in charge of anything that doesn't fall under Medicaid, which is the behavioral health organization used to help fill the gaps. For instance, you have somebody that doesn't have medical insurance, or they can't get it because they're not here legally, or Medicare doesn't pay for something for somebody, and so how do they get treatment, which all of these things impact, and the behavioral health organization handles that. Well, now it's gone to the managed care organizations. We're the last region for that to happen in the state, so that's a good thing, and that we have the other regions to see how it's going so far and beginning to work on some of the issues that they've had. So I think that's a positive thing for us. But nevertheless, there's going to be services, gaps in services, and that we need to fill, and figure out where are the gaps and how are we going to fill those to make sure people get the services they need. So there is a group that meets called the Interlocal Leadership group, and they've turned it over to another group that's called an operating group, and they were supposed to meet monthly, and we got the report at our meeting last week that they're not needing to meet monthly right now. They're now they were meeting monthly to help all the agencies get set up with this new way of billing and being paid for their services in agencies, especially when we have small ones like we do in Mason County. I mean, it's kind of scary that all of a sudden you can't just bill the Medicaid that you normally have billed. And you would know from the hospital and getting payment and stuff and how difficult that can be. So they were working monthly on that, and I think everybody's on board now, so they've cut the meetings less, and now they're probably waiting to hear problems that are arising. So that's kind of where we are with the managed care organizations. But there are representatives from this community that are involved in them, and I think you're one of them.
Yeah, maybe I can fill in a little bit.
Yes.
So I our county's representative on the BHA SO now, and I also represent the county on the ILS and the JOC.
Thank you.
And I'm waiting to be appointed to the EIEIO. All these acronyms, it's great. But basically that's the troubleshooting organization, the troubleshooting arm that was sort of developed with the Medicaid transition that we're going through here now, but has already been happening in other parts of the state. As that process moves forward, as you hear things from providers that you're talking to in the community, it's really important that trickles up to us so that we can relay that information to both of those groups and try to work through the issues before they become their own kind of a hurdle to people getting served. The other thing I'll say that I hope as this transition continues to move forward, that this group is mindful of other needs that we should be asking the MCOs to provide. In other parts of the state where the transition has already occurred, they're funding projects and staff and other opportunities in those communities. And so we should be putting together our wish list of sorts that we go back to the MCOs with. We'll give you an example. In Island County, I was talking to some of their folks last year. They provide a public health nurse that they pay for to the county. It's things like that that could help fill in those gaps that we should be asking the MCOs to provide, and they have a track record of doing that. So kind of keep your ear to the ground, and when you're hearing of issues, bring them to us. If there are any ideas that we should be asking the MCOs to provide, bring those forward. I think that's going to be a point of emphasis for our group throughout this year and beyond.
And we have Molina, AmeriGroup, and United are the three managed care organizations in the county that we're working with. Molina is very visible, and they kind of have been participating for a number of years in our community. They've helped sponsor meetings and forums and things. The other two aren't as visible. But we met with Molina. We came in.
But I believe it's AmeriGroup that's providing the nurse in Island County.
Okay.
So, you know.
But we don't have AmeriGroup anymore.
Mm-hmm.
Oh, we have
Oh, yeah, we have AmeriGroup. Molina.
Coordinated care.
We don't have coordinated.
Yeah.
Well, coordinated care is actually only for foster care in our
Oh.
county. Foster care children, yeah. And then Dave had a piece that I think I agree with, a question to ask the MCOs, and it would be around infrastructure. And, you know, because we've heard a couple of things. We heard from Mark this week, Friedman, that they aren't willing, the contract states that if anything wasn't in place as of July 31st in 19, they don't have to fund it. So what happens when you have new innovative projects and things coming down to help improve services and nobody's going to fund them? So kind of interesting kinds of things to look at and talk to them about. And then building infrastructure, how do you build infrastructure? They always, you know, money comes down for services but never for administrative or other infrastructure that needs to be there to be able to provide services. So. And that's something where the money used to funnel down to the agencies. The BHO did give that kind of money to agencies. So, another gap.
Okay. Public comments?
Yes.
Okay.
Thank you. This is great. I just love the way this is laid out, so you can make your notes right next to the subject. So thank you for that. I guess I have a question. I'm a little confused about the results for fatal overdose use on page 9. It says that 40 individuals had used their naloxone kits to successfully save someone's life, and that seems to be confirmed on the little top graph here on page 5, where the number 40 comes up again to reverse an overdose. And then when you turn to page 6, are we to assume that the number of fatalities from a drug overdose would be 52, had it not been for these people saving other people's lives? I guess the question is, what's the resource on that? How do we know that the lives were saved? I understand that they were used for that purpose, but those numbers carry through the report, so I was just wondering, is it just as somebody comes in and says, I'm looking for a refill because I used my last one to save somebody's life?
That's some of that data, yes, comes from that direction.
But the
yes.
12 is from different, the 12 that
the
are
actual
verified.
fatalities literally comes from our coroner.
Oh, that comes from the coroner?
Yes, it
so,
comes
so
from
the
the
12
coroner.
we are very comfortable
Yes,
with.
yes.
But there's a possibility there could have been 52 overdose deaths?
I guess what the comment was that if we didn't have Narcan in those 52 cases, could they have possibly overdosed and died? I think it's what the comment was that I heard. So
Which is a potential, but we don't know for sure.
Okay. Just the way it was written, I thought it was a positive,
like there was a report and someone came out, there was an ambulance and there was something along those lines. I just want some clarification on that. With regard to the suicides and the veteran population, the advantage of dealing with the veteran population is it's very specific. You either are or you are not. There's no mixing up. And it's been our objective at Memorial Hall to remove the veteran population from as much as practically possible from the services in Mason County so they don't become encumbered when there are other options like American Lake that are available. And we do that to the extent that we're able to do it with the Veterans Assistance Board, also with their finances and so on. But we have no information on veteran suicides other than the national statistics. So we have no way of identifying it, and we're not trained. We're just volunteers. So we would naturally reach out to people who had showed signs, unobvious signs of committed suicide. Is there any statistics for the veterans in Mason County for the number of suicides, and could, in terms of age and, well, just age would work in the beginning. Do you have any specifics?
So I'm the epidemiologist for Mason County, so I would know, no. The answer to your question is no, because our numbers are so small. The veterans population is small to start, and then the number of veterans that would potentially commit suicide, it's such a small number that we don't have information on it.
Well, we have 7,326 veterans. That's 12% of the population. That's a lot of guys.
Sure.
We don't know them. We only know the people who come to the VFW for the meetings and for services and that kind of thing. If there was information, I'd just appreciate if we could avail ourselves of that so we could reach out.
Does it say if they're a vet?
Yeah, on the death certificates, because I read every death certificate, and they're not identified as veterans on the death certificate.
But that might be
Now, we'll
changed.
know if they come in to get their free copy,
Correct.
because veterans do get one free copy of their death certificate. But other than that, it would be difficult to find out.
Okay. Okay. Thank you.
Anything else? Motion to adjourn?
So moved.
Yeah.
Oh.
Board comment. Just,
Okay.
So the other thing I was chatted with Dave briefly yesterday. He had sent out an email to solicit some future agenda items. One of the ideas that I had and wanted to bring it forward to the board, and this would probably make Scott happy, but we've seen a influx of new providers in the community.
Yeah.
And I thought it would be helpful if Dr. Stein is on board with it as well, as if we were inviting some of those new providers to come in and talk about their work in the community, how we could be supportive of them. And I know predominantly they're up at Mason General, but maybe more broadly in the county, at all levels, whether they're MD or DO or a PA or an MD. You guys have done pretty good at hiring here lately.
Yes.
And I think it might be informative to our work as policymakers to hear what they're saying and how we can be supportive of their efforts.
Would you be willing to meet early in the morning? If we had a breakfast up at MGH, first thing that came across my mind is we're taking these providers out of the clinic seeing patients, and that isn't our normal goals. But if we go ahead and do a breakfast and have the health board come up there, we could have each provider stand up and give a little bit of the background and what their specialty is. Would that be beneficial?
Be fine with me. I don't know that the rest of the board would help, what their schedules are like or whatever, but we can work on figuring it out. I think it would be worthwhile.
I'll run it past Eric and get back to you.
Oh yeah, I mean, we have the protocol.
You do a special meeting.
Is your goal to just ask to get feedback from them
Get to
as
know
they're
them,
seeing
yeah.
it?
Yeah.
Get to know them. Because I was wondering if we videoed them.
I know I'd like to know the options.
There are some videos that were done.
Yeah,
for
it's
Mason
true.
General and some of the new providers.
Yeah, I'm not necessarily looking for biographies. I'm looking for kind of on the ground perspective of what they're seeing in their daily practice and what
maybe what they
what insight they
specialize
can
in, or-
what they can bring
We
to our
wouldn't necessarily
conversations.
have to have them all at the same
No,
time.
I meant
Maybe
just kind of
somebody
periodically, as their
that would be
schedules allow, we don't have to
interested.
have the whole.
And that way we
every
wouldn't
new
have to
provider
all
you
travel.
get, maybe offer it to them. If we found a way to just do an invitation And, you know, I know
Yeah,
schedules are.
You didn't mean everybody at once, right? I thought you
No,
mean that one.
no.
I was saying,
No.
I don't know if I'd like that one, but
No,
I
but
like the
mean,
idea
you know,
of
throughout
making the invite.
throughout the course of the year when they're available, to have an open
Yeah.
invitation to come and meet with the Board of Health. I think there's an opportunity for us to work much more closely with our provider community and understand some of their challenges. And I think about that not only in trying to understand some of the health issues that they're trying to treat and improve, but also, you know, what we ought to be thinking about as we try to attract more providers to our community as well.
We're out of space.
We're just built a building.
Yeah, build another one.
Well, and also you can use me as a resource. I do try and attend the staff meetings, and I'm not a provider in Mason, but I do see patients in Thurston. And so if you wanted to kind of have me address this, the providers at the staff meeting, offer anything like that, or
Yeah, I think that'd be great. I think
get some feedback.
you'd be the appropriate conduit there, so.
Right.
That'd be cool.
I'll let you do it.
So the other thing I brought up today was that it would be nice to have Alex come in with maybe your team that you use for septics.
Yeah,
A
sure.
septic
I can do that next
Yeah.
week. Do that next
Because-
week, that'd be easy.
Because I really don't know that much about them and what's required in the county and
We have
all-
unique challenges here with septic
and
systems.
all the things you have to go through and
Yeah.
just
Gravitated,
Yeah.
gravitational comfort.
yeah.
Yeah, I know Debbie's in the past brought staff from all our major programs in, you know,
So then if
maybe one at a
somebody-
time at the board
Yeah.
meetings, just kind of introduce them and talk about their programs a little bit. We could do something like that again.
But that way, if somebody asks me a question about it, then I might have at least, of course, I would just send them to you, but
Yeah.
an intelligent answer.
Yeah, no, we can work on that.
Okay. Anything else? Anybody? Okay.
Move my turn. Second.
All those in favor?
Aye.
Let's adjourn at 4 minutes.